Hello everyone, my name is Jennifer Traverso. I'm here to present my DNP project, a quality improvement program, smoking cessation in patients with chronic pain. I choose this project because it is oftentimes seen in the pain management clinic that patients who smoke complain of more pain than patients who do not smoke. Smokers oftentimes demand for more pain medication than non-smokers. The vicious cycle of smoking and increased pain is seen in many instances in the pain management clinic. Despite the accountability of morbidity and mortality, smokers continue to smoke. So it is important to reinforce a consistent clinical practice guideline on smoking cessation in the pain management clinic. I would like to express a special thanks to my instructor, Dr. Maria Snell, and my chairperson, Dr. Rita Wonderling, for their unending support and guidance throughout the course of this project. I would also like to thank the committee members of this project, Dr. Ortolani, Dr. Lago, and our clinic manager, Joan Ortolani, who believed in me and supported me throughout the course of this project. Introduction. There are evidence and studies that showed a link between smoking and increased pain in the pain management clinic. Other evidence also suggests that smokers who use tobacco as a coping mechanism for chronic pain, and the reason people continue to smoke is because of addiction to nicotine. Studies show that people who smoke perceive more pain than people who do not smoke. Furthermore, smokers who have chronic pain use more opioids and have higher pain intensities than non-smokers. So why do people smoke? Smoking is very addictive. Cigarettes are deliberately designed to give you a fast nicotine hit. Nicotine is a stimulant, and it only takes 10 seconds for the drug to reach your brain from inhaled cigarette smoke. Understanding the concept helps a researcher review the standards, policies, values, and recognize the main attributes of the concept: willingness, motivation, dedication, commitment, and fortitude. Both healthcare providers and the patients must have these attributes to obtain a good outcome of the project. Analyzing the concept of cessation will address and understand the concept as it relates to the prevention of negative outcomes by promoting healthy behavior. So why stop smoking? Smokers demand for more pain medication. Smokers use more pain medication. Smokers complain of more pain than non-smokers. Smokers are at risk of narcotic abuse and misuse. Smokers are at risk of street drug use. Smokers are at risk of alcohol abuse. Smokers have hard time managing their pain. Smokers have higher risk of cardiovascular and peripheral vascular disease, cancer, and other diseases. So the purpose of this quality improvement program is to implement a consistent clinical practice guideline in a pain management clinic using the 5A's rule of smoking cessation. Healthcare providers need to reinforce and implement the smoking cessation program in every patient encounter to help patients take the necessary steps to stop smoking and manage their pain better without getting more pain medication. Background. Tobacco products contain highly addictive nicotine. Nicotine is a stimulant that makes people feel good, but also carries negative health effects. However, people continue to smoke to get the reward sensation of feeling good from chronic pain. People who smoke are more likely to experience more pain and demand for more pain medication than people who do not smoke. People who cannot get more pain medication are more likely to use street drugs and alcohol to relieve their pain. To break the cycle, healthcare providers in the pain management clinics have the responsibility to educate smokers to stop smoking. Therefore, it is imperative to implement clinical guidelines to healthcare providers and provide the necessary tools to educate their patients in participating in smoking cessation education. Although nicotine has mild euphoric effects, smokers use this strategy as a coping mechanism to reduce pain. Therefore, we have to understand what nicotine is. Nicotine is a stimulant. It is highly addictive and dangerous. Nicotine has similar effects as cocaine and heroin. Cigarette and tobacco contains nicotine. People who smoke have more pain. People who have more pain demand for more pain medication. People who cannot get more pain medicine turn to street drugs for pain relief. Street drugs is the root cause of violence and crime. It is critical to implement and enforce smoking cessation intervention using the 5A's model in the pain management clinic. Significance. The significance of this project is to help smokers engage in the smoking cessation program aside from offering the multimodal approach to pain management. Smokers at the time of pain consultation mostly reported significantly worse pain intensities than non-smokers. However, smoking cessation in the intervention clinic is not consistently implemented, so recognizing the importance of smoking cessation in pain patients with chronic pain provides an opportunity for healthcare providers to easily incorporate the 5A's rule in smoking cessation and use this smoking cessation strategy as a training tool for healthcare providers in the pain management clinic. The 5A's are ask, assess, advise, assist, and arrange. Again, the significance of this project is to establish a consistent clinical guideline for smoking cessation using the 5A's model. Incorporate 5A's model as part of the employee training program. Incorporate the 5A's model as part of the multimodal approach to pain management. This will help reduce and manage pain, prevent use of street drugs, and stop the vicious cycle of smoking and pain. So what is the purpose of this project? The purpose is to manage pain, decrease opioid use, discontinue opioid use, decrease cigarette use, discontinue cigarette use, educate patients, and assist smoking cessation. The project aims to help smokers stop smoking to help manage their pain better without demanding for more pain medicine. It also aims to determine if the 5A smoking cessation program help patients decrease the need for more pain medicine and possibly decrease opioid use. Literature review. There are several studies conducted on smoking and pain. Many studies found that smoking increases pain and interferes with pain management. Literature review theme. The synthesis findings from the literature on smoking and pain were found through a rigorous selection process of finding the theme, like smoking and pain, smoking cessation, the 5A's model. The search for these key elements through data collection and analysis, the reviews found in the articles were summarized and synthesized thoroughly. There are several studies regarding smoking and pain, and this is studied by Houghton, Kahn, and Weingarten. Smokers have more pain, have higher pain intensities, use more opioids due to chronic nicotine exposure by Houghton et al. 2011. And then smokers have chronic pain, use more opioids, and have higher pain intensities than non-smokers by Kahn, Ha, and Mackey 2019. Weingarten 2015 reported that there is an increased smoking behavior in patients with fibromyalgia, and subjects believe that fibromyalgia contributed to the increase in smoking. Smoking impairs oxygen delivery, reduces healing and recovery after injury, and that is from Kahn in 2019. Several studies found the benefits of smoking cessation prevent morbidity and mortality not only in the United States but also applies nationwide. There are also literature and relevant studies regarding the 5A's model. Flack and Antognoli 2017 reported the application of the 5A's model in a primary care setting found to be important because it provides direction and magnitude of measurement in tobacco cessation and examines the method of the advice. Vijayaraghavan et al. 2017 found that there is a need to conduct a clinical practice guideline using the 5A's model of smoking cessation. A consistent application of the 5A's at every patient encounter in the mental health clinic supports the hypothesis that implementing the 5A's can promote abstinence and smoking reduction when delivered for at least 12 months. Dixon et al. 2009. Furthermore, several studies reveal that people who smoke perceive more pain than people who do not smoke, and people who have more pain use more opioids and smoke more than people who do not smoke. Smoking is associated with increased pain. Increased pain may also make smokers want to smoke more. In Kahn's study found smokers who have chronic pain use more opioids and have higher pain intensities. Bellum 2015 also found that people may turn to heroin because it is cheaper and easier to get than pain medicine. And Flack and Antognoli 2017 reported the application of the 5A's model in primary care. There are recommendations from health organizations regarding smoking cessation. The U.S. Preventative Task Force 2015 highly recommends clinicians to screen for smoking status and provide smoking cessation intervention using the 5A's approach. The quality measure summary recorded sufficient evidence that smoking cessation is successful in outpatient setting when implementing tobacco screening and counseling. There's also evidence that healthcare workers who intervene and counsel smokers to abstain from smoking with minimal intervention of fewer than 3 minutes increase overall abstinence. Patients who do not get more pain medicine may use heroin or cocaine because street drugs have the same effects as opioids. Theoretical framework. Roy's adaptation model, RAM, has been used to guide interdisciplinary knowledge development, interdisciplinary education, practice, and research to ground nursing research in a theoretical framework to provide a better comprehension in our healthcare system. In this project, we use Roy's adaptation model to guide interdisciplinary knowledge to provide a better comprehension in our healthcare system. RAM viewed the individual as an adaptive system that responds to environmental stimuli by 4 modes: physiological, how a person responds to his or her environment; self-concept, how a person defines himself or herself; role function, the social status, autonomy, self-control, interdependence, relationship with others, and social support. Sample. This project is a quantitative exploratory design through a retrospective chart review that will be utilized for this project. The participants are identified as 30 female or male patients who smoke and have chronic pain, aged 21 to 80 years old. Patients are seen every month during their narcotic refill. Smoking cessation intervention using the 5A's is implemented in every narcotic refill in their monthly visit. The narcotic data collection tool is recorded in every visit. The study will last about 3 to 6 months. The data is recorded as part of the patient's medical record. Monitor progress in every patient is monthly for the next 3 to 6 months. Methodology. In this project, the researcher will record a minimum necessary data to accomplish the goals for this project on the data collection sheet. Implementation strategy includes: it is a quantitative method, study design, the 5A's model of smoking cessation, ask smoking status, advise to quit, assess willingness to quit, assess to quit, arrange for follow-up and support. It is a chart review, and we do audits, convenience sampling of 30 patients, setting projected time frame table is about 3 to 6 months. All potential identifiers will be removed and will not be collected for this project. The setting of this project is in a pain management clinic, Daytona Beach, Florida. It is a private practice which employs 2 medical doctors, 3 ARNP, 3 physical therapists, 2 office managers, and 40 medical assistants. The specialty is pain management and neurology. We have physical therapy, aquatic therapy, EMG, MRI, trigger point injection. Patient population is adults and elderly. There are 30 male and female patients on this project and 18 years and over who smoke cigarettes and experience chronic pain. During the recruitment process, each participant will be assessed during their initial visit using the 5A's approach. Their pain level will be assessed and smoking cessation educational handouts will be given. The patients will then reassess on their 2nd and 3rd month's visit, again using the 5A's approach. Data will be gathered on each visit and compiled in the EMR. A total of 30 EMR will be retrospectively reviewed at the end of the 3rd month. The inclusion criteria on this project is: the EMR has documentation that the participant is 18 to 80 years old. The EMR has documentation that the patient smokes nicotine products. The EMR has documentation that the patient was seen in the pain management clinic between November 1 through January 31. The EMR has documentation that the patient was provided a 5-ACE method of smoking cessation. The EMR also has documentation that the patient's baseline second and third visit information on smoking usage and pain level. Electronic medical records of potential participants will be excluded in a specific order. Exclusion criteria. The participants will be excluded if they are less than 18 years old or greater than 80 years old. If the EMR has no documentation, then the patients and they are not smokers, the EMR will be closed and no data will be retrieved. If the EMR has documentation that the patient was not seen between November 1 and January 31, the EMR will be closed and no data will be retrieved. If the EMR has documentation that the patient was not provided or was provided the 5-ACE method of smoking cessation, the EMR will be closed and no data will be retrieved. If the EMR has no documentation of the patient's baseline second and third visit information, then the EMR will also be closed and no data will be retrieved. Steps of intervention and timeline. The project was prepared in the course 701 in August 2018, and the site and IRB approved was on December 2020. Data collection was provided on January 2021, data analysis April 2021, and summary report was August 2021. This is the sample of the data collection sheet and the data collection tool. And this on the first row is the chart, and the number 2 is the 5-ACE, the ask, advise, assess, assist, and arrange, and all data was collected and retrieved at the end of the third month. This is the educational handout distributed during the first visit. This is another handout to give patients a resource from CDC to call this few phone numbers so that they can speak to a trained coach. On the data analysis, we use the Wilcoxon Signed Drunk Test. The Wilcoxon statistical test was conducted to compare a paired measure between smoking and pain, and the pre and post intervention were measured at 2 different points. The Wilcoxon Signed Drunk Test showed that smoking cessation intervention elicit a statistically significant change in patients with chronic pain, and the rank score on the first month was 14, and the second month was again recorded, and as well as the third month. By examining the final test statistics based on the study showed there is an overall statistically significant difference in pain scores, and the value score was therefore reported that the Wilcoxon Signed Drunk Test is using the Z statistics. The ranks table presented a significant data on comparing the pre and post intervention scores. In general, 22 participants presented higher pre-intervention pain scores compared to the post-intervention. The instrument used identified the patterns of assessing smoking status and pain. The data collected was utilized to measure the effectiveness of the intervention. A retrospective repeated measure design is effective in assessing pre- and post-intervention. The 5-ACE model was an evidence-based framework. Descriptive statistics and exploratory research presents the description of the events when smokers finally decrease the number of cigarettes and quit smoking. Results. The results reported that the Wilcoxon Signed Drunk Test showed that smoking cessation intervention elicit a statistically significant change in the patients with chronic pain, and by examining the final test statistics based on the study showed there was an overall statistically significant difference in pain scores. In general, 22 participants presented higher pre-intervention pain scores compared to the 8 participants post-intervention. Limitation. The retrospective study suggests that there was an evidence that some smokers are willing to quit in response to pain. The study also suggests that there was a significant correlation between smoking and pain intensity. The smoking cessation intervention affected smoking behavior among individuals with chronic pain. The study also showed that increased pain was a motivator for smoking, but was limited in this study. The limitations in this study include that the subjects were not investigated in great detail, and there was no formal face-to-face interview. Qualitative studies are highly subjective, difficult to assess. Small group is limited, not large enough to obtain accurate data, and patients did not complete the program study. Some of the patients did not complete the program study. Discussion. As we all know, smoking exacerbates pain. Now we also know that smokers who have more pain than non-smokers, and smokers who have chronic pain take more opioids than non-smokers. Smokers use cigarette, tobacco as a coping mechanism for pain relief. Smokers who have more pain demand for more pain medication. Smokers who cannot get more pain medicine may turn to street drugs for pain relief. So the discussion is, we need the social change. Why change? The pain management clinic do not have a consistent clinical guideline to assist patients in smoking cessation. The smoking cessation intervention guideline in the pain management clinic is not persistently enforced. Healthcare providers do not have proper training to help patients to implement smoking cessation intervention. Healthcare providers in the pain management clinic do not have time to implement smoking cessation intervention. Smokers are not consistently educated about the effects of smoking on pain. Smoking cessation intervention is not a part of the multimodal conservative approach to pain management. Smokers do not get adequate pain relief from pain medication because of chronic exposure to nicotine products. So why implement and apply the 5A's approach? It is because it is a patient-centered model. We have to ask tobacco use, explore patient-centered care, develop the care plan that tailor the patient's needs, advise to quit, educate patients, deadly effects of nicotine in a clear, strong, personalized manner. We have to assess the willingness to quit, monitor patients, assess and reassess tobacco use, assist to quit, formulate a plan, assist the patient's willingness to attempt to quit, use counseling and pharmacotherapy to help him or her quit, arrange for follow-up and support, schedule follow-up contact in person, by telephone, preferably within the first week after the quit date. And this intervention is at no cost and only takes a few minutes at each office visit. Therefore, we need to establish a clinic guideline for smoking cessation, implementing the 5A's approach. Again, ask, advise, assess, assist. Assist, provide help for patients to quit smoking, walk them through the 5 hours exercise, relevance, risk, rewards, roadblocks, repetition, and arrange a schedule for follow-up. So what is the implication for future practice? It is a commitment to pain management. The application of the 5A's model cessation with or without electronic healthcare record software. It manage pain, it decrease opioid use, it discontinue opioid use. Hopefully, educate patients deadly effects of nicotine and smoking, incorporate the 5A's model as part of the multimodal approach to pain management, incorporate the 5A's as part of the employee training program in the pain clinic, use consistent practice guideline using the 5A's model. Again, as part of the pain team, you have to commit to smoking cessation, patient-centered approach, practice consistent clinic guideline, incorporate the 5A's model as part of the multimodal approach to pain management. Healthcare provider needs to implement the 5A's model, manage and decrease pain, decrease opioid use, and prevent this vicious cycle of nicotine use. Conclusion. Therefore, we need to set a shared vision, provide a consistent clinical practice guideline using the 5A's model, incorporate the 5A's model as part of the employees training program, enforce and apply the 5A's model at every patient visit, incorporate the smoking cessation program as part of the multimodal approach to pain management. So the application of the 5A's model to smoking cessation program: ask tobacco use, advise to quit, assess willingness to quit, assist to quit, arrange for follow-up and support. Therefore, we need to set a global vision, universal application of the 5A smoking cessation, application of the 5A's model to smoking cessation intervention in every patient encounter. Successful intervention begins with every healthcare provider. Incorporate the 5A's model to new employees training program. Incorporate the 5A's model in the multimodal approach to pain management. Setting a SMART goal. SMART, what is SMART? S, set specific goal. M, measurable goal. A, attainable goal. R, relevant goal. And timely. We need to start with a short-term goal. Distribute and provide smoking cessation, educate smoking cessation, post-smoking cessation, and incorporate the smoking cessation as part of the pain management program. Our long-term goal for this project is to practice consistent clinic guideline using the 5A's model. In the pain clinic, incorporate 5A's model as part of the employee training program. Incorporate the 5A's model as part of the multimodal approach to pain management. Healthcare provider will implement the 5A's model in every patient encounter, manage and decrease pain through smoking cessation, discontinue or decrease opioid use, prevent vicious cycle of nicotine use. Thank you everyone for listening. Again, my name is Jennifer Traverso. If you have any question, you can call me at 386-281-7978. My email address is jtraverso1@live.maryville.edu. Thank you very much. God bless.